Hello, everyone, and thank you for attending the GE Healthcare-sponsored SCCT webinar titled A Technologist's Guide to Cardiac CT Protocols, When Less is More. My name is Mike Withers, and I'm the Clinical Product Manager for CT at GE Healthcare. Before we begin today's content, I'd like to cover just a few housekeeping items. For the best viewing experience, we recommend using a wired connection and closing any programs or browser sessions running in the background. Webinars are pretty bandwidth intensive, so closing any unnecessary browsers or tabs will help things run a bit more smoothly. We are very fortunate today to have two distinguished presenters from the University of Chicago. Dr. Luis Landeras, who is the Associate Director of Cardiac CT and MR and Associate Professor of Radiology, as well as Imaging Technical Coordinator Michael Mason. Dr. Landeras and Mike will take you through some of the challenges associated with cardiac CT imaging, as well as some key points and technologies to help alleviate those hardships. Make sure you stick around after the end of the recording for a live Q&A session. Dr. Landeras, I'll turn it over to you.
Good evening, everyone. Welcome to today's presentation on the Technologists' Guide to Cardiac CT Protocols. My name is Luis Landeras, and I'm an Associate Professor of Radiology and Interim Co-Director of Cardiac CT and MR at the University of Chicago. With me is Michael Mason, our CT Imaging Technical Coordinator. We are honored to be here and excited to share our insight and experience on how we perform cardiac CT imaging using a wide detector CT technology. Thank you for taking the time to join us. Let's get started. Here are axial images of a coronary CTA examination. As you can see, there is beautiful depiction of the coronary arteries, which are motionless and demonstrate no atherosclerotic disease. You can see that the right coronary artery along the right AV groove terminates in the posterior descending artery. You can also see the left main coronary artery essentially trifurcating into an LAD, ramus intermedius, and circumflex artery. As expected, this acquisition was obtained with ECG gating, and in this particular case, at the end of diastole, this beautiful data set allows images to be reformatted into 3D volume rendering reconstructions for better visualization of the coronary anatomy. This other data set is part of the same examination obtained from the same patient, just before to the prior acquisition that I just showed you. As you can see, the right coronary artery is in this particular case awfully blurred and cannot be easily distinguished. Looking at the ECG gating tracing, we can appreciate that the patient had a much faster heart rate, which significantly interfered with the optimal visualization of the coronary arteries. This is an example that we had earlier when we started using our wide detector CT scanners. Owing to the rapid motion of the heart and the small structures to be imaged, coronary imaging is one of the most challenging clinical applications of CT. It requires a very high temporal resolution to freeze the motion and allow visualization of the coronary arteries and root. It requires high spatial resolution, which is important to visualize the arteries, possibly small pseudoaneurysms, and dissection flaps. It requires high contrast to noise ratio that is needed to resolve small structures, including the atherosclerotic plaques and their components, and also needs high low contrast resolution with load limited radiation dose. This is particularly required when doing perfusion imaging. As with any CT acquisition, but more importantly in coronary imaging, there is a complex interaction between the patient factors, the administration of IV contrast media, and the CT acquisition parameters, which combine help to determine a good quality diagnostic acquisition. Further supporting the CT acquisition part of this relationship, there is some post-processing that can be done to improve image quality, including ECG gating, editing, advanced AI-based reconstructions, and motion correction algorithms. Among the different patient factors that affect image quality, body habitus is one of the most important. Patients' height and thickness, including weight, chest circumference, and BMI play a major role. Imaging patients with greater than 30 to 35 BMI can be pretty challenging. Age is also an important consideration when performing cardiac CT imaging. It is not the same to scan a child than to scan an adult patient. Additional standard considerations applicable to all CT acquisitions also need to be taken in consideration, including allergies and kidney problems. Heart rate, baseline and variation, and the presence of arrhythmias are also significant variables to take into consideration with imaging the heart. Continuing with the cardiac imaging challenges on the patient side, there are several specific factors that make the acquisition particularly more difficult. Among these are the presence of large calcium burden and stents, as well as fast and irregular heart rates. A patient that is fully compliant and uncooperative or possesses a large body habitus significantly increase the difficulty of this study. And several of these factors affect various parameters on the CT acquisition. Now let's just focus on CT acquisition itself and the key specific parameters that are challenging during coronary CT imaging. Temporal resolution is considered a key parameter to successfully perform CTA cardiac imaging. The coronary arteries move rapidly and in a complex manner throughout the cardiac cycle, so fast gantry rotations is a primary requirement. By rotating the gantry quickly, a large number of images can be acquired during a single RR interval, and this improves the chances of capturing the heart in the desired phase of the cardiac cycle. Fast gantry rotation times is routinely combined with ECG gating techniques to allow reduction or elimination of motion artifacts, improve visualization of the coronary arteries and the heart, as well as accurately measure cardiac function. There are generally two categories of ECG gating imaging. In the retrospective mode, the X-ray beam is turned on at the same time of the acquisition, and the images are synchronized with the heartbeat after the fact. In prospective ECG triggering, the X-ray beam is turned on only after the recognition of AR peak during a specific portion of the cardiac cycle, and when the highest chance to image the heart motionless. As you are probably aware, in cardiac CT examinations, we aim to image the heart during the diastolic phase because this is a portion of the cardiac cycle where the heart has the least motion. Keep in mind that the diastolic phase decreases with faster heart rates, limiting your chance to image a still heart. In general, a temporal resolution of approximately 200 milliseconds is enough to image a heartbeat at around 70 beats per minute, and approximately 150 milliseconds is needed to image a heart rate of approximately 100 beats per minute. Let's take a look at this ECG tracing to put this into perspective. If we have a patient with a heart rate of 60 beats per minute, the RR interval is approximately 1,000 milliseconds. A typical CT scanner with a 300 millisecond gantry rotation will have an approximately 150 millisecond temporal resolution. And we should be able to successfully image the heart during systole. If you happen to have a dual source CT scanner, your temporal resolution is significantly better, 65 to 75 milliseconds, and you can image even faster heart rates. Even with a faster heart rates and decreasing diastolic phase duration, you can still get diagnostic quality images if multi-segmented techniques are used. It is important to note that if your patient has significant arrhythmias, including atrial fibrillation, and patients with fast heart rates, acquiring images at end systolic phase might be more beneficial. Let us take now a second look into how retrospective and prospective ECG gating works and their advantages and limitations. As we mentioned earlier, during retrospective ECG gated imaging, the X-ray beam is on and synchronized to the ECG tracing while we acquire the data to reconstruct the images. Because the table is moving as the gantry rotates, we obtain a helical acquisition. The classic described advantages of retrospective ECG gating imaging is the fact that you obtain functional data as you image the entire cardiac cycle. And therefore, you can compensate for arrhythmias using ECG editing or reconstruction of different cardiac phases. The main disadvantage of retrospective ECG gating imaging is the higher radiation dose associated with it. This is typically due to the very low pitch that is needed, around 0.2 or 20%. There is a 80% overlapping of data during this acquisition. This redundant data is what allows the reconstruction of different phases and our ability to just eliminate nonspecific extrasystole while maintaining excellent image quality. In prospective ECG gating, the X-ray beam is typically only on during a specific portion of the cardiac cycle, where we have the highest chance of finding the heart motionless. In this example, the first heartbeat is used to obtain data from the upper half of the heart. The second heartbeat allows the table to move to the lower half of the heart, and your third heartbeat completes your data acquisition. All of them aim to image at the endostalic phase. This type of acquisition usually results in significantly reduced radiation doses and no helical artifacts. In general terms, it does not provide functional data. You only get images from that portion of the cardiac cycle where the X-ray beam was on. However, now with a wide detector CT scanners and the ability to do one-bit imaging, this is not exactly the same. You can actually obtain images of the entire cardiac cycle using prospective triggering. The classic disadvantages of a standard narrow detector do not apply. You still cannot do ECG gating editing in the same sense though. Trying to understand temporal resolution a little bit better, we know that specialized cardiac reconstruction algorithms use information obtained from 100 degrees gantry rotation to create a single image. This is what it looks like for a single detector. If you have a gantry rotation speed of 250 milliseconds per rotation, then your temporal resolution should be approximately 125 milliseconds. With a dual source CT scanner, because you have two X-ray beams, two X-ray tubes perpendicularly oriented with the respective detectors, you only need 25% Ganti rotation to obtain the 180 degrees of data and able to reconstruct your image. Because we use a CT wide detector scanner for our cardiac CT imaging needs, we try to take full advantage of the technology that is included with the scanner. One of these tools is the auto-gating option, which records the patient heart rate and assesses heart rate variability prior to the diagnostic acquisition. Based on these parameters, it chooses one of 28 different profiles with the highest chance to image the patient most successfully. This is a view of the console as the technologists get to see it before acquiring the study. As you can see in the red circle, this is the section where we choose the auto-gating option to be on and off, and we select a specific profile to perform the auto-gating. After we have chosen the protocol and the patient is set up on the table ready to be scanned, we obtain a test recording. That looks at the patient's heart rate and variability. And based on that, the tool automatically chooses a specific protocol. I know this is a busy slide that shows the University of Chicago CCTA with function profile, and you can see a variety of parameters that we can use to image these patients. We have the average heart rate on the top and the heart rhythm on the left, with variables as stability, irregularity, and high irregularity. Let me draw your attention to a couple of examples. Let's assume that your patient has an average heart rate of 60 beats per minute, which is pretty stable. This patient would be imaged with these specific parameters. This acquisition would be done at 75% of the cardiac cycle, and the reconstruction would be a center phase acquisition. But what would happen if the patient heart rate were 75? In this case, we will go with these parameters. We will obtain diastolic and systolic imaging, and we will perform the reconstructions with a smart phase and snapshot freeze, which I will explain shortly. The smart phase tool analyzes the motion of the coronary arteries through the acquired volume and automatically selects the best cardiac phase with the least expected motion. In general, it does a very reasonable job at choosing the base phase, but you still have to check it. On the scanner console, this is the section where we would choose the smart phase option. The other tool we routinely use is the snapshot freeze, which is essentially a motion correction algorithm. Currently in their version 2, we actually have version 1 on our scanners and works pretty well. This is what we typically get to see on our side. This is done not on the scanner console, but in the 3D post-processing software, the AW workstation. You can see that we have 3 different data sets: the whole heart cycle, which has information of all the different acquired images reconstructed at 10% intervals, the temporal smart phase series that has 3 data sets, which are used to create the motion corrected snapshot freeze, which in this particular case was 60%. You can see that 60% acquisition, the RCA is motion free. Now let's talk a little bit about spatial resolution. Coronary arteries are small vessels with diameter tapering from 5 millimeters in the left main to around 1 millimeter in the distal LAD, the coronary artery, stenosis, and atherosclerotic plaque caroticization demand accurate depiction of small structures, so high spatial resolution in 3 dimensions is a must. To differentiate 10 to 20% stenosis, isotropic resolution of 0.3 to 0.5 millimeters or smaller is desirable. This is actually easily achievable in the XY plane even before the multi-slice era, but it was not until the arrival of the 64 multi-slice CT scanner that proper through-plane Z-axis resolution was achieved. In this sense, detector Z-axis coverage is a major determinant in the axis resolution. Although sampling frequency, interpolation algorithms, and detector design also play a role. If we are talking about spatial resolution, we need to talk also about longitudinal Z-axis coverage. The length of the detector array in the Z-axis is another key specification when obtaining a cardiac CT examination. Ideally, the cardiac volume would be covered in a single heartbeat, considering that the cardiac anatomy is typically 12 to 14 centimeters, and the majority of hand-end scanners still use a shorter Z-axis coverage length. We need to implement different techniques to be able to cover the anatomy of interest. We have already mentioned the step and shoot technique, in which a series of slabs are obtained over several heartbeats with a minimum number of heartbeats possible to allow for a comfortable breath hold. This slide looks at the same principle in a different manner and highlights that in order to cover the cardiac anatomy with a 4 cm detector width, we need 4 different gantry rotations and the heartbeats in between. However, with a 16 cm width detector, this can easily be achieved on a single heartbeat acquisition. Another approach to obtain whole volume coverage with a single heartbeat is available on the dual source CT scanners. On the Siemens dual source systems, a high pitch greater than 3, prospectively ECG trigger helical mode is available. In this so-called flash mode, a single heartbeat imaging is possible, although this mode is somewhat limited to the patients with low heart rates, typically less than 60 or 65 beats per minute. Finally, another element that we need to discuss here is the fact that we need powerful X-ray generators capable of delivering very high currents, typically in the 600 to 1000 mA range, to provide sufficient photons to deliver adequate image quality. The newest Revolution CT scanners we currently use at our institution deliver up to 13 mA when using 70 kV. This parameter is particularly important in patients that are obese and when you are using a lower X-ray to potentials such as 70 or 80 kV. The use of new reconstruction algorithms such as iterative reconstruction and AI-based reconstructions have reduced this need, but it's still nice to have enough photons to be able to get a good contrast to noise ratio images. This is the version AI-based image reconstruction we use on our scanners. It is referred as deep learning image reconstruction or true fidelity. It uses deep neural networks to generate low noise images and high definition. This is an example of this technology. We have here a calcium score CT examination. This study was done on a patient that required pre-op assessment prior to liver transplant. You can see there are significant calcifications in the coronary artery. There are pretty sizable pleural effusions and significant ascites. All these challenges and the use of low-dose technique has resulted in quite a bit of noise in the field of blood projection image on your left-hand side, which is significantly reduced in the DLR reconstruction. Now that we have covered some of the specific parameters that are particularly important when acquiring CT cardiac imaging, let's take a look at things from a slightly broader perspective. You have your top-of-the-line CT scanner, and now you have to decide how you will scan these patients' cardiac or coronary examination. This is just an example, but you can appreciate the complexity of this algorithm. How we will perform our cardiac CT examination on a particular patient needs not only to be specifically tailored to answer the clinical question, but also deals with a considerable variety of options. Is the patient's cardiac rhythm stable or unstable? Do we need functional information? Given that coronary artery imaging is frequently both, are we doing prospective sequential, high-pitch helical, or retrospective spiral imaging? We at the University of Chicago prefer a slightly more straightforward approach. We have multiple scanners and technologies with very different backgrounds and experiences. So trying to keep things a bit more straightforward really helps. We try to minimize the number of protocols and variables that technologists need to deal with, and the technology available on our CT scans certainly contributes to our approach. This is a short summary of the protocols that we actually have available, and we perform the majority of our cases. Of course, we have a non-contrast calcium score study. We have a coronary CTA protocol that includes, in the majority of cases, functional assessment, pulmonary vein protocol that easily incorporates coronary arterial assessment if needed, and a TAVR protocol that we use for our transcatheter aortic and mitral valve procedures, as well as minimal invasive robotic surgeries. Now let me have Mike talk to you about how we actually acquire our coronary CT examinations.
Talking about acquiring coronary CT examination, I'm going to go through the steps and how we actually perform and go through a coronary examination. We start with the intravenous access that we use. We need an IV that you can use a high flow rate with. Should be a 20 gauge IV or bigger, but 20 gauge is sufficient for small patients and normal patients. For larger patients, 18 gauge catheter is necessary sometimes, so we can get enough contrast at a higher flow rate. But the 18 gauge can allow up to 7 cc's per second. Generally, we wouldn't go 6 or 7 cc's per second unless we really have to, but most of the time, 4 to 5 cc's a second is sufficient for the coronary CTs that we do. We want to try to use the right antecubital vein whenever we can. It's preferable, or at the right side of the vein, it's a larger vein, because the left antecubital vein will contrast. You can result in streak artifact that passes over the arch that you can see in the pictures here. In the bottom, you can see where there's a lot of streak artifact here on the bottom. And this one on the top, not so much, but there's a potential for obscuring the anatomy if you're looking for the arch. That's why we normally would want the right antecubital vein for our cardiac studies. As far as breath hold for the patients, it's good to rehearse breath holds with the patients so they can know exactly how you want them to hold their breath. Sometimes people have harder times holding their breath. So it's good to practice and just notice the rhythms and the patterns that the patient has when they're holding their breath. So you should really give them specific instructions and tell them exactly what you want them to do. And also, we try to make sure that we put the leads on first, because we really want to see what the heart rate does when they hold their breath. Generally, most patients, when they're holding their breath, the heart rate will lower, but you want to notice that pattern to see how much it does lower. So also, you want to ensure that the quality of the breath hold is good. You don't want them to do a Valsalva movement where they're bearing down, because actually you can wash out some of the arteries when you do that. So we really don't want Valsalva, just a good, solid breath hold. And we want to time it so we can actually, we want to take the scans before the actual heart rate goes down. When actually we inject, usually it takes a few seconds for the heart rate to go down when the patient holds their breath. So kind of keep that in mind when you're scanning, because you don't want to tell the patient to hold their breath and start scanning right away, because sometimes it takes a minute for the heart rate to stabilize. You also want to make sure you observe any changes or fluctuations in the heart rate and rhythm, so that you're able to better gauge how the scan is being done. Also, you want to minimize any artifacts that may be in the way. High density material, such as leads within the scan field. Most of the time, the leads won't be in your way of your heart field of view if you place them in the correct areas. So that's normally not a problem, but you also want to make sure that there are no artifacts that are going to obscure the anatomy or anything else that you're trying to look at. It's very important to position the heart within the center of the gantry by adjusting the table height or lateral position, because most people with normal body habits, their heart is slightly to the left and it's more toward the anterior of the chest. So it goes against conventional CT positioning. If you're positioning for another type of test, you want to make sure that heart is right within the center of your scan field of view, so that there's no chances of missing or clipping anatomy. You want to make sure the patient's supine with the arms above the head and they're in a comfortable position, so they're not straining or trying to hold their arms up. If you need to place positions, pillows, or sometimes you may need to use another positioning device to help the patient hold still. So we want them to be comfortable. We don't want them to strain, basically. So the more relaxed the patient is, the better your scan is going to come out. The arm with the venous access, you want to make sure you keep that straight to avoid line kinking, especially if the IV is in the antecubital area, because most technologists know that if the patient's arm is bent when they're trying to inject, that can cause the injection to either stop, or sometimes extravasations can happen. So being that we're using a high rate of injection, we don't want to do this. We want to make sure we're careful with that. You can move the patient through the gantry for the expected scan range to ensure that the lines or leads are not tethered. You want to make sure that nothing's tangled and nothing's pulling. A lot of times, if you're doing a gated scan and you have a nurse there, they have leads as well, or other blood pressure cuffs or anything else that a patient may have attached to them. You want to make sure that everything can move back and forth without the potential of either pulling or ripping. And you want to make sure the patient doesn't touch the gantry at all. You want to place the leads outside the field of view. As we said in the previous slide, to avoid streak artifact. Here's the positioning of where the leads normally would be. This is more of a positioning thing where you want to kind of put near the upper chest on the right and left sides, and then the lower rib margin. Those are better landmarks for lead positioning. You also want to make sure that the patient doesn't have excess hair or excess oils on their body, and that may need to clean off. Sometimes you can use a prep wipe or a prep sponge to wipe the area before you place the leads, and make sure the area is dry as well, so that you can get good skin contact. Now, it's very important to obtain a steep upslope towards the R peak and sufficient R peak voltage with minimal baseline noise. Now, basically, if you're looking at the waveform, your R peak is peaking high, your S is down, but then you got the T wave here. You want to make sure it's not as high as the R wave. So the amplitude may be close. You want these to be a significant difference between your R wave and your T wave here. And if you need to reposition the leads, make sure you do that. You don't want to make sure that you everything is connected correctly, and then you have a nice even waveform when we're doing this. As far as contrast media, we like to use something between 300 and 370 milligrams for iodine per milliliter. Most of the time here, we might use Omnipaque 350. Different hospitals use different types of contrast media, but you want it to be at least 300 milligrams of iodine per milliliter. Injection rate 5 to 7 milliliters per second. Generally, we don't try to go below 5 cc per second, even for the small patients. I mean, sometimes you may have an issue where the IV is not as good. Sometimes with a smaller patient, you may be able to get away with a slightly lower injection rate, but I would not recommend going below 5 unless you absolutely have to. That's why it's important that you have the IV that you need. The overall volume is a function of the injection rate and injection duration. As far as contrast volumes, 50 to 120 milliliters. Generally, we don't use more for coronary studies, maybe 65 to 70 milliliters. If we're doing a study that we're trying to evaluate bypass grafts or other anatomy such as the aorta, we may use up to 90 cc of contrast, or if the patient is a little larger, we may use up to 120, depending on what we are trying to image. As far as the timing of the IV contrast bolus tracking, we want to make sure that we trigger it at a pre-specified level. You put your ROI, we usually use a descending aorta to do this. The scan is triggered when reaching a predefined threshold. Now, sometimes what you can do, at least we do, you may either have an automatic start or you may have a manual start where you can start the bolus and scan on your own. As far as test boluses, sometimes people use them, but to me, that takes a little bit more time, but I would just like to make sure we have a nice rate of injection and the contrast is going well. I like to start mine manually so I can better guide what happens as far as the contrast flow and when to start a scan. Here's an example of the coronary scans that we've done. You see the nice even waveforms here, nice high R peak, smaller T peak. Your resting phase here is ideal. It's ideal for the scanner to actually pick up when the scan. So this is destined probably to be a good scan. Note the nice even waveforms here. As far as triggering, we had a preset threshold of 120 Hounsfield units here. Because of the blue line, this was started by the technologists. If you have an auto start, then it will start on its own once it hits the threshold, but having the technology started as soon as it passed the threshold here. And if you can look in the time and seconds it took to get to that peak, and the ROI measured 140 Hounsfield units here. This is the tracker, and that's where it measured 140 there. So you can kind of see it went past the threshold. And that's what you want when you're doing a coronary scan, to make sure you got the even waveform and nice contrast bolus. At times we use the biphasic injection. We want to make sure that we wash the right heart chambers out, because you want to see your contrast in your left ventricle and your aortic root and your coronary arteries come off the aortic root. So that's what you really want to see. So there's not a lot of artifact or anything like that. You can look here. We got a pressure graph. Basically, we like to set our pressure that maybe 300 pounds per square inch, but here is 280. It tracked pretty well. And a flow graph, if you look here, the contrast is here. And then you have the saline here. So this scan was 90 ml of contrast was used. This could have been a TAVR pulmonary vein or something like that. It could have been a larger patient with a coronary. And you can see what the actual milliliters per second that the injector gave you. Sometimes it's close to 5, sometimes it's, most of the time it'll be close to 5, so you won't have any issue with that. So we inject the contrast first, and then the saline goes right after. typically the same injection rate. Sometimes when you have different types of IVs that may or not work as well, sometimes we will reduce the saline injection rate. At times, you may have extravasations of saline versus contrast. So it's all about your patient, really. If you know your patient has decent veins and there are not any other issues or any flow issues, then you can typically use 5 cc's per second. We use a triphasic injection. We want to desire a pacification of the right side of the heart as well as the left. This is the 81-year-old patient with a prior medical history of hypertension, AFib, diabetes mellitus, TIA, and COPD. Her left atrial appendage prior to possible placement of a closure device such as a Watchman or ambulance device. Now, if you look at the arterial phase, you see your left atrium and you see like a small artifact clot there. You do a delayed phase to ensure that that's exactly what it is. If you see on the delayed phase where you still see this clot, so you pretty much know that that is a clot versus some type of artifact. For CT acquisition, we generally start below the tracheal bifurcation and extend it below the lower cardiac border. So on this scout image, the tracheal bifurcation is about here. And the lower margins of the heart, lower cardiac border is here. So you want to make sure there's no clipping of the anatomy. Generally, if you look at your anatomy, the brachial bifurcation there, the aortic arch is here, your pulmonary artery will be right below that. Usually below your pulmonary artery, your pulmonary veins start to come in. You'll see where the aortic root would normally be. So generally, if you know you're starting above the pulmonary artery and tracheal bifurcation, you'll be well above the start of the coronary artery origins. You also make sure you don't want to clip the apex of the heart here. If you're doing for a bypass graft, you may have to scan a little bit higher, like to get the subclavian artery, And sometimes they will use a Lehman graft to graft from subclavian artery to the either the Lehman, the right side of the heart. So they use that left internal mammary artery for use bypasses. Sometimes they use saphenous vein grafts as well. But you just want to make sure that if you're scanning for a bypass graft, make sure that you scan or know the anatomy and make sure you scan the area that you need so you're not missing anything. This is just an example of where the tracheal bifurcation would be, lower margins of the heart, apex here. This looks like it's a pretty good collimation here. Right side of the heart here, left side of the heart is there. It's very important to make sure that we get the anatomy that's needed. So with experience and the more scans that you do, the easier it is to visualize these things. Most people, if you're starting, you want to make sure that you use this type of area. If you're doing your first cardiacs, use the tracheal bifurcation as your upper landmark, the apex of your heart, the lower margins as your inferior landmark. As far as tube potential, typically 80 to 120 kb is sufficient for cardiac imaging. Very rarely will we do 80 unless we're doing a very small adult or a child possibly. It's recommended to use 100 kb when the patient is below 100 kilograms or the BMI is under 30. Increased radiation exposure is proportional to the square of the tube voltage change. Tube current, most scanners modified to adjust for patient size and weight and desired image noise. Increase in the radiation dose is directly proportional to the change in tube current. Generally, we'll try to use KV more than we would try to use MA. We still want to try to keep the dose low. So KV would be the thing you use first. If you need to increase the MA, the tube current, then you can do that. But you generally want to make sure that your scan time is very low. Here's an example of a coronary CTA protocol. The autogated study. The profiles use a UFC CTA with function. That's what it is. Gating based on the latest heart rate, because in part one is 75%. 100 MA snapshot freeze is on. If you look at the graph, actually, you can look and see where the scans. This is more like where the P wave would be. But generally, like I said, if you have a lower heart rate, your R interval will be a lot longer. So that way you have better area, better increased chance of getting the heart imaging at the resting phase. Also, the KB mode is all the prescription here. That's generally what most of our cardiacs are done, because it actually will tell you or suggest what MA or KB to use. As for this one, 100 KB was used. The smart MA, 100 to 1080. Noise index of 32. Local spot extra large. As far as the reconstructions, you can basically have regular coronary CCTA reconstruction. You have a smart phase reconstruction with a snapshot freeze, which actually kind of targets the best heart rate and gives you images correlating to that target heart rate. The best images, where the scanner actually says the best images come from. You get a whole heart cycle where you can actually mimic a functional type of image where you can actually make cines and look at the heart function and motion. And any other reconstruction that you need, you can create it or change the phases, whatever you need to do.
Now, let's look at some representative cases obtained at our institution. Actually, the cases that you're going to see, in the majority were obtained last week, so they are very fresh and representative of what we tend to do on a regular basis. And this is a 61-year-old female with past medical history relevant for COPD, diabetes, hypertension, and hyperlipidemia, presenting with chest pain, and known anomalous right coronary artery on CTHS imaging. These are the 75% center phase, the 36% smart phase, and the 36% smart phase snapshot freeze reconstructions. You can see that the patient heart rate was slightly on the higher end, was 71 at the time of the acquisition. A closer look at the right coronary artery. You can see the vessel is coursing between the aorta and the pulmonary artery, and appears significantly blurred on the center phase 75% acquisition. It looks significantly better on the smart phase, but is even better depicted on the motion corrected 36% phase. The curve NPR reconstructions proved very challenging to obtain the takeoff of the vessel proximally. The 36% smart phase did a better job looking at the takeoff, although there was significant image blurring proximally, and the snapshot freeze 36% reconstruction actually gave us the best visualization of the proximal RCA and the remaining of the vessel, even in areas where it was significantly blurred on the other reconstructions. This is a 33-year-old male patient with history of chronic Crohn's disease and chronic TPN with short bowel, history of prior myocarditis and pericarditis with chest pain. We are asked to evaluate for coronary artery disease. You can see this acquisition had a much higher heart rate. We are running 81 to 84 beats per minute. The acquisition actually went slightly over to try to compensate for this fast heart rate, but the obtained images actually are of excellent quality for a relatively high heart rate. And the dose obtained on this examination was 145, which is still pretty low. This is an approximately 2 millisievert acquisition. This other example is of a 91-year-old female referred for TAVR evaluation. You can see that aortic valve leaflets are thickened and calcified with limited excursion. The three-chamber view demonstrates significant calcification extending into the LVOT. This patient heart rate was actually pretty high, 109 at the time of the acquisition. However, using a snapshot freeze and a smart phase, the acquisition is still proved significantly good for assessment of the coronary arteries. Keep in mind, this study was not done for the evaluation of the coronary arteries. I just decided to reconstruct it to see how good the coronary arteries would look like. And you can see we actually did a very good job. This portion of the RCA is somewhat blurred. But in general, this is still a pretty reasonable study. This is another example in which true fidelity and a snapshot freeze was used in a patient with a 70 beats per meter acquisition. You can see that there are some calcifications in the left main, proximal LCX, which is non-obstructive. This is another case in which true fidelity for high resolution, the DLIR high setting was used to reconstruct the images. This is a patient with history of mitral valve repair and heart failure, and they are asking us to evaluate the amulet device. The location of the amulet is noted in the left atrial appendage, although the disc appears to be just proximal to the left atrial appendage orifice, and there is a persistent opacification of the left atrial appendage. There is also a bioprosthetic valve in the mitral position with a vascular flag and a small pseudoaneurysm / aneurysm adjacent to it. And with that, I thank you for your attention, and we will proceed to the questions.
I'd like to thank our All right. Thank you, Dr. Landeras. Thank you, Mike, for going through all that excellent information with us. You've been doing a great job keeping up with the questions as they've been coming through, but just want to get some of these over to you, and we can do some live Q&A now. Looks like Tanner has a question regarding scanning on a GE Revolution Apex with a 16 cm detector. Do you suggest to scan patients using prospective or retrospective gating? Sounds like they've had some motion issues even with some of the technologies in place. They would like to know, what scan mode would you suggest that you scan most frequently in?
Thank you for your question. Actually, we do have a GE Revolution. We have a couple of Apex scanners, all of them 16 detectors. What is actually a little bit counterintuitive is that this scanner actually doesn't do retrospective gating. Even when you acquire the entire cardiac cycle, that's prospective triggering. You acquire all the information, but there is no helical acquisition. There's no pitch, there's no overlapping of data in that strict sense. So our friends in GE, they still refer to this as prospective gating, even when you acquire the entire cardiac cycle. I know it's a little bit contradictory to the classic thinking of it, but it's prospective acquisition. Now, we don't run into a lot of issues in this way. What I would suggest is I wonder if you're letting the smart face choose the scan for you. As I was mentioning in some of the questions, We think the smart face does a very good job, particularly when it tries to get the least motion on your RCA and then does the motion correction on that vessel. But sometimes that takes you to your LAD being significantly degraded, especially you have a lot of that soft tissue and calcified plaque. Makes it very hard to figure out how much stenosis you're having. So what we usually do is use that whole cycle acquisition, which is already done every 10% of the cardiac cycle. And we scroll through that data set, find the one that has the least motion on the LAD, and then do a motion reconstruction algorithm around that vessel. So you will see the smart face with that snapshot freeze for the RCA, and you will look at the LAD with a snapshot freeze in a different phase. We find that one tends to be very good, and we rarely have any really scans that we cannot clear completely.
Perfect. Okay, looks like the next question is, what are your thoughts about using DLIR or True Fidelity high on elevated calcium scores in stent placement patients?
And that's a very interesting and provocative question. I mean, the issue with elevated calcium is the blooming artifact. And that has to deal more with spatial resolution rather than noise. So DLIR obviously is going to get rid of some noise, but I don't know how good it will be able to get the calcium out. We'd like to use a very wide window level setting, 2700 width, around 900 level, and that almost looks like a bone window, but slightly less washout. And that decreases the blooming significantly enough that I can see the lumen of the vessel if it's patent and well opacified. We scan everybody. We do all the reconstructions with DLIR. That's what we tend to basically have. But you know, there are issues, the stent issues, the calcium issues. If you know you have a lot of calcium, sometimes I feel it's better to keep it at 120 kVp rather than to go to 100 or even 80, obviously, because then you have so much blooming that you get into issues. Our friends on heart flow CTFFR, they don't like to go and try to assess the CTFFR when you have less than 100 kVp for your acquisition. So I would, if you happen to do a calcium score or you know from a prior CT that the patient has a lot of calcium, I would try to stick to the 120 and use the LIR as usual, but for a different reason, not necessarily for noise reduction.
Excellent. Next one is for Mike. I think you might have gone through this during your section, but just as somebody had asked, with your cc's of injection, 4 to 5 per second, what do you find is your total volume that you're utilizing per patient?
Well, standardly, we would use 70 ml of contrast for a standard patient. And that's usually sufficient enough to see everything we need to see. And as far as higher injection rates, we only use those mainly on larger patients or somebody with a larger body habitus. But generally 5 cc's per second is the standard that we use.
Excellent. Do you use beta blockers on all patients, or can you just scan at a higher heart rate with your system?
Oh, the magic question. We wish we could get away from beta blockers. We still sort of need them with faster gantry rotation times, faster temporal resolutions. I think we are getting there, but we still use them regularly on every patient that we can. Sometimes it feels also that also helps to stabilize the heart rate once you give the nitro to vasodilate, kind of counterbalances a little bit the slightly higher heart rate that you get when you give the nitro. So we still use beta blockers regularly.
Do you have any suggestions or tips on patients that have variable heart rates or AFib with obtaining CCTA studies?
Go ahead, Mike.
Well, one thing that we try to do if we know we have a patient with a AFib or any type of arrhythmia, we'll try to rehearse breath holds with the patient and kind of see what the pattern of the breath hold is. We'll try to see whether or not the heart rate drops when you hold the breath for a few seconds, 5 to 6, 7 seconds. We kind of gauge where we need to scan by that. If we need to start the breath hold in an earlier spot before the scan starts, that helps a lot, I find. If you can get that patient to hold their breath a little bit earlier, maybe a second or two earlier, and get their heart rate a chance to stabilize. And with the scanner we have, if by chance you may catch the scan on that irregular heartbeat, it knows it's smart enough to correct itself and actually get a scan where you can get a decent, I would say motion, not say motion free, but as least motion as possible. You can get that scan because the system corrects itself.
Excellent. Which threshold do you usually use on the descending aorta with GE64 slice? Is it 100, 120?
I don't think 100, 120 makes any difference. You can use 150 you feel like. The 100 just tells you the contrast has arrived. You keep that in mind. The 100 it means the contrast has arrived. You still have to build a slight delay on top of that depending on your scanner speed. And some of these scanners, the table speed is very different. Sometimes I work with a different vendor where the scanner table will take forever to get to the start position. So that was a drawback. So the 100, 120 doesn't make any difference. It just means the contrast has arrived. After you have figured out that the contrast has arrived, you need to build a delay on top of that. That is what needs to be adjusted depending on your table gantry speed and where is the start of your scan. But in general, it doesn't really matter. That is 2 seconds. If you are sampling every 1 second, that will be 1 second difference or 2 second difference. Given that most of us are using 60 ml of contrast or 70 ml of contrast, you have plenty of contrast to deal with it.
Perfect. I think we have one more question here for you. Do you utilize anything in combination with your beta blockers at all?
Just the vasodilator. We tend to actually go for 0.8. I know a lot of places use 0.4. Feedback from our experience with CTFFR and research studies have shown that actually 0.8 tends to make a difference. I was a 0.4 before believer, but now that there's some actual data that shows 0.8 makes a difference for vasodilation and trying to assess hemodynamic significance, then we prefer to use 0.8 with the beta blockers.
Perfect. Okay, I think we are going to close out the session here. Dr. Landeras, Mike, thank you again so much for your time and all this valuable information you've provided to everybody. Looks like there are a couple more questions. We will do our best to get those answered after the webinar, and then this will be available through both the SCCT and via the YouTube page afterwards. So thank you, gentlemen, again for your time, and thank you to everyone who has participated and for listening and all of your questions. Very much appreciated.